let's have a few words about the surgical management, and especially the elective management, what treatment options we have available for the elective procedures and what treatment options we can keep reserved for the emergency situations. Okay, so we have extracorporeal shock wave lithotripsy. That technically means that we are using some specific type of the waves for the breakdown of the stones, and obviously the larger stones, which are maybe in centimeters, when we give them extracorporeal shock wave lithotripsy, then they are break down into the fragments, and these stones are then passed along with the urine, giving a good fluid resuscitation and good hydration therapy to the patient. In this particular technique, okay, so this is a plain radiograph, and you can see that right here, the ureter, and there are some radiopaque stones here in the right ureter. So how are you going to go for extracorporeal shock wave lithotripsy? There are some waves which are being used, and they can be piezoelectric waves, they can be spark gap waves, or they can be electromagnetic waves, and they are set on a specific frequency, and then they're shot in the fragment, the bigger stones. They are break down into the smaller segments, and these fragments can pass on by just the millimeter. The fragments are in millimeter, and they can pass with the urine. The main problem with the extracorporeal shock wave lithotripsy is that there is a possibility that there can be renal parenchymal damage, or there can be hematoma, and especially with the spark gap, when you're using the spark gap waves for the extracorporeal shock wave lithotripsy, then you have to do the ECG monitoring as well, because these waves can actually generate arrhythmias, and a patient can suffer arrhythmia or a cardiac arrest because of these arrhythmias. So monitor ECG changes and attach the monitor, the cardio monitor, whenever you are dealing with extracorporeal shock wave lithotripsy with these spark gap waves. Now there are complications, and these complications you have to remember is that there's a possibility there can be renal parenchymal damage, there can be ureteric damage, or there's a possibility there can be hematoma, or there can be hemorrhage as well because of these waves. The other thing you need to keep in mind that there are some conditions in which you don't have to perform ESWL. Okay. Like in pregnant females, you don't have to do this, and because these waves are highly damaging to the fetus, and they can cause teratogenic effects in the fetus and abnormalities as well, and they can hinder the developmental processes as well. Then there's another contraindication to extracorporeal shock wave lithotripsy, that is obesity, because in obese patients there's a possibility that you may use the high frequency waves, and then you can damage the internal organs, and there's a lot of tendency to the renal parenchymal damage. So keeping in mind these extracorporeal shock wave lithotripsy contraindications, you can do is you can plan for the emergency surgery, and you can plan it for the elective surgery as well. Uteroscopy is becoming more fascinating and famous in this particular era, and for that you just have to go per urethral, and most of the time there's a catheter. You just enter, you just gain entry from the urethral orifice down to the hole of the tract, and then you can inject the dye, and you can use this fluoroscopic imaging just on the films, and whole of the tract of the ureters and the pelvis. You can actually see whole of the lower urinary tract. Now, with these uteroscopy, you can use some. There are some retrieval baskets, and even counter any stone. These stones can be retrieved into the basket, and they're then pulled off. But sometimes stones are bigger enough, and what you have to do is you have to use particular mechanical techniques to break down the stones. And when they are fragmented with the lithotripsy techniques or with the mechanical force, then you can actually retrieve these stones in the basket, and then they can be removed. But the complications or related to the ureteroscopy, one of them is that there's a possibility you may damage the ureteric mucosa, and then there can be infections, and there can be urethral constrictions later on, and then later on you have to do the ureteric dilatations. So these possibility of damage to the ureteric mucosa, and the possibility to damage later on causing the ureteric strictures is one of the complications for the ureteroscopy. Otherwise, it's a very good technique. You can use a dye, and you can visualize the whole of the lower urinary tract, and then they can be used not only to visualize, but you can see the bladder surface and bladder mucosa as well. And then the stones can be retrieved as it is, or they can be broken down into the fragments, and then they can be removed from the body. So again, so this is a picture of just first insert the ureteroscope. There's catheter along with that, and this is the retrieval basket, okay? So what you do is you just insert it, there's a stone, open it up, and hold that stone into this retrieval basket, and then you can just pull it back. That's how you can remove the stone with the help of the ureteroscopy. And after this, that you have to keep your patient on the irrigation, and if you have done this ureteroscopy, you have to hydrate your patient. It's good fluid therapy post-operatively is very important for good healing and good antibiotic cover as well. Percutaneous nephrolithotomy is meant to be for the procedures, and like in pregnant moments in which extracorporeal short wave lithotripsy cannot be used, or there are complications that may be possible. You try to do the ureteroscopy initially, but you were failed, or the stone is very larger enough that they cannot be retrieved with a ureteroscopy. So you go for percutaneous nephrolithotomy. So you're just using, most of the time it can be done by the urologist, but interventional radiologist can also do this procedure. And all the way you inject the catheter from the skin, the particular flank part back, and then just you have to insert the catheter down, and then you have to just give the dye. Fluoroscopic imaging techniques are being used, and then you can retrieve the stone with the help of the percutaneous nephrolithotomy, which is the PCNL, or it can be called as a mini PCNL. And sometimes you have to leave a nephrostomy tube with the help of that, and you have to keep the nephrostomy tube for 24 to 48 hours, and then you can. So this is actually the fluoroscopic imaging guiding, and this is the guide wire, and you are trying to break down the stone or retrieve it with the help of this nephrolithotomy. Right here, this is the stone, so you have to get all the way under the imaging guidance, all the way here, and then you can retrieve the stone into this, and you can just keep the nephrostomy tube for 24 to 48 hours, which can be later on removed. So this is actually the dye is reaching down here. This is the part of the kidney, and these are the calcial system. This is the renal pelvis, and down here coming to the ureters, and this is a stone which has to be retrieved by the help of the percutaneous nephrolithotomy. But in some conditions, open stone surgery is usually not done in a modern era because you are going or heading towards non-invasive procedures. Like ureteroscopy is the best one. For the larger stones, you can do the PCNL or a mini PCNL. So, but you should know what in open stone surgery, what you have to do. You just have to make the just a renal incision and just mobilize and go to the retro, because if your approach should be from the back, because if you're it's a posterior approach. But if you go from the anterior approach, there's a possibility you will encounter the peritoneum and you have to lift up the peritoneum and immobilize the whole of the structure. So obviously, anterior approach would be difficult. Usually, for the nephrectomy, you can go for the anterior approach. But you do the posterior approach mostly for these open stone surgeries, and by mobilizing the rest of the colon and additionally the peritoneum, and then you can reach the kidneys and just give a small vertical incision in the kidney and just get rid of this perinephric fat. You can see here all the way, and the incision is given, and this is the parenchymal system. So you can see the renal pyramids, the columns, and the pelvic calcium system, and then the stone can be retrieved by this technique, which is open surgical technique. This is not used today, but they can. But you should have a little bit of the idea how you do. So most importantly, we follow the posterior lateral approach for this and mobilize all the structures and reach the parenchyma, get rid of the perinephric fat, make a small vertical incision, and go down to the renal pelvises. And this is open stone surgery is usually reserved for the renal stones, maybe upper middle or the lower lobe stones. But for the ureteric stones, yeah, you can do it with a PCNL, or you can go for pyelothotomy, or you can go for the ureteroscopy. These are the techniques which are actually used. So in today's topic, we try to discuss about the renal stones, their presentation, their etiology behind, how you're going to go for diagnosing these patients, what investigations are important that going to help you with how you're going to treat your ureterocolic in emergency, and what is a medical therapy and how effective the medical therapy can be, and what size of the stone can be treated with the medical therapy. And the size of the stone will actually guide you towards a medical therapy or a surgical therapy. And then the treatment options we have available for the surgical management, like extracorporeal shockwave lithotripsy. We try to discuss about their complications. We try to discuss about their contraindications, and we talk about the ureteroscopy, open surgery, and percutaneous nephro, and the pyelolithotomy. So that's all for today's lecture. Thank you for watching sqadia.com. Keep watching sqadia.com with Dr. Sana Khan.